This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. LaFredo. According to a 2022 article in the journal Healthcare, overcrowding in emergency departments is a phenomenon that is now widespread globally, and it's one that has led to an increase in mortality and morbidity, and a decrease in the ability to provide critical services in a timely manner to patients suffering from medical emergencies. My guest today brings insight and expertise to this conversation. He's Dr. Adam Dawson, and he's the medical director of the emergency department here at KRMC. Dr. Dawson, welcome to the program.
Hello, thank you for having me.
Thank you for having me. We're here in your office. I have a bunch of questions about the ED and how it works. First, I want to talk about the guest we have sitting in on this conversation.
Oh boy, so you're asking about lightning bolt.
Okay, yes. Tell me about lightning bolt.
Lightning bolt is a tarantula. My parents caught lightning bolt. At first, we didn't know he was and we didn't know he was lightning bolt. My 7-year-old Natalia named him, and with some research by one of our medical students, there's certain findings on him that we were able to decipher that, in fact, it is a boy tarantula. I bring critters in. I've got scorpions, I have tarantulas, I've got some other pets, including a dead black widow. But I like to teach, especially the kids, but also as a physician in the ER here, I teach residents and medical students, nursing students, etc. And so he comes in to be a prop to help teach some of these things.
Do you see a number of scorpion stings or related cases here?
Quite a few a year, yes.
Yeah. Well, this was a surprise to find him here set up, and so thank you. You did make me sign a waiver, so I think I'm safe. But
if you want to hold and pet later, we can do that.
I don't, but thank you for the offer. We're here today to talk about the ED and how it works and sometimes how it doesn't work. So, Dr. Dawson, emergency departments have a long history of extended wait times. Why does it generally require a long time to see a doc in the ER?
Short answer, it doesn't require it, but it seems to be a common issue. A lot of hospital systems find themselves backed up with patients. You know, you go to big areas, including just an hour and a half away to Vegas, and they even have billboards, electronic signs where they're quoting how quick you're going to see a doctor. They're trying to recruit business to that facility. Patients theoretically are business in that world. In a small town such as this, obviously, it's not quite the same, is it? Because we're not trying to recruit extra clientele or patients per se. We're just trying to take care of the community that we have, right? And so why is it happening? I think the issue is just trying to keep up with how many patients come into any facility as communities grow and as you grow the facility thereafter, because the facility grows as the community does, but not necessarily before the community does.
Mm-hmm. For the lay audience, how does triage work?
Triage, we could spend a day on triage, just having that conversation in the lay version of that conversation.
Yeah.
But legitimately, nurses get signed off and trained and certified to be able to do triage work. The triage process, you have to have some general idea of what the condition is. You have to have a set of vital signs, such as heart rate, blood pressure, and those types of things. And then a decision gets made using a scoring system. The scoring system helps decide how severe the condition has potential to be and how much resource is going to be required to handle the situation. Most ERs, not all, but most ERs, including here, we've got a process where if someone has a lower condition or lower acuity, as we say, theoretically we can take you out of the mainstream for critical issues and put you through a faster process. But that doesn't always work depending on if there's way more patients. And I can come back to that in a minute.
Yeah, I think we will, right? You never know what's going to walk in at any given moment.
Extremely true.
Yeah. We're talking about ED or ER wait times. Is it fair to say they've gotten worse in recent years?
It depends on who you ask, and it depends on the community. From my standpoint, no. Recently, as in a couple years ago, when we first started having the extreme version of staff issues, and we had an increase of patients with COVID issues, in fact, yes, it was worse. And we saw worse waits than we've ever seen, not just locally, but nationwide. Having said that, compared to a couple years ago, it's gotten much better. We still have day-to-day variance, and so there might be a good day and there might be a bad day, but I think overall we've seen similar concerns that ebb and flow for quite some time.
Yeah, you mentioned COVID and the strain that put on the medical system, EDs in particular.
Mm-hmm.
after the initial onslaught of the patients, there was also the attrition. We heard a lot of stories about physicians and nurses just leaving because of burnout.
Yeah, so there was a quote that we lost 20% of our nursing staff nationwide. Locally, regionally, we felt that. When we go to Nevada or when we talk with our California colleagues, it's not unique to this area right here. It's all over, you're right.
When we talk about overcrowding in the emergency department, is it fair to say that some percentage of that goes to patients who are using the emergency department as primary care?
Absolutely, but I try not to be overly critical of those individuals. We realize that people are struggling to get help and get care. Many of the people who come in and their condition is not an active heart attack, it's something that's been going on for weeks, sometimes even months. They've been trying to do it the right way. Our colleagues in primary care, they're having similar struggles. Our struggle of overcrowding, you can see it in the lobby. Their struggle of overcrowding, you see it in wait times, people trying to get into an office. And so it's happening industry-wide in the practice of medicine. One of my favorite patients was a sweet little grandma lady who came in. She waited. This was within the first couple years of COVID, when in fact we had the most ridiculous number of patients in the lobby we've ever seen, and ideally we will never see that again. But she had waited 7 hours to be seen. She came into the room. I came in apologizing to her, just expressing how absolutely sorry I was that she waited so long, how we absolutely wouldn't want that for her. She stopped me in my tracks, and she says, "Look, I know I'm not having a heart attack." She said, "Just thank you for being here. I promise I've been trying to go in through the typical avenue." But she says, "I have 6 or 7 months of abdominal symptoms." And we walked through it. Was this an emergency today? Well, theoretically, we could have come in yesterday, or we could have come in a week from now, right? But she was one of my favorite patients because she was so appreciative. Despite the errors in the system, she said, "Thank you." I think what I learned from her was the fact that, hey, the whole system's imperfect. By the way, you and me as people, we're imperfect. And I think maybe what we could do is just learn to show kindness to each other, show appreciation, be understanding. And I loved this woman for that. She really helped me that day.
We're talking about overcrowding at the ED. What role does health insurance play in that conversation?
You know, this is a point of frustration for a lot of people. This is a frustration for people who don't have insurance. This is people who are begging to pay their insurance. For us in the ER, we don't like it either. It's frustrating. We're really hoping we can just help, and instead we're dealing with the chaos of the politics, the money. Part of why I became an ER doctor was to stay as far away from money as possible. As it pertains to the overcrowding in insurance, well, some people don't have financial connection to their care. Maybe they're not paying a copay or whatever. A lot of people across the nation have become frustrated by this. And I'm talking about actual healthcare people who are frustrated by this, because sometimes we see abuse in people coming to the emergency department. Having said that, there's no point in getting burned out on it. It's not worth it. I'm here to help. We're here to help. There's a friend and a person I respect who, despite other people getting burned out, he wasn't getting burned out. And in asking him, "Hey, what about these people who are abusing the system?" He says, "You know what? They just don't know what you know. They're here because they don't know, and we're here to answer those questions anyway. So let's just help them out." And that stuck with me. So Dr. John Baugh, that's what he said.
Shout out to you, Dr. Baugh.
Yeah.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week I'm in the emergency room. My guest is Dr. Adam Dawson. He is the medical director of the ED here at KRMC. Dr. Dawson, KRMC has numerous channels for treating patients. There's Same Day Sick, which offers telehealth appointments for non-emergent conditions. There's your primary care provider. There's KRMC Urgent Care. And then, of course, there is the emergency department. How does a patient know which of these is most appropriate for a given condition?
That's a really good question. I'll tell you what, if your symptom is something that is dangerous or feels dangerous to you, then you want to escalate who's evaluating that. Primary care and urgent care are both very capable in managing those questions and helping guide patients through that. But if it otherwise seems life-threatening immediately, then you should just come to the emergency department regardless. The majority of conditions, though, can be started at any one of these locations. If this is something that's been going on for days, weeks, or months, oftentimes it can be managed through a primary care office. You mentioned the multiple ways that the hospital system is trying to help care for all these patients. I appreciate most especially the primary care offices. They've been opening up a lot of same-day sick visits for patients, trying to incorporate some of their individual patients to be able to come in that process. It's been able to offload some for the urgent care and for us in the emergency department.
And urgent care is something that's urgent, but something a little bit less than what we typically think of for the emergency department.
Yeah, so the urgent care does an amazing job, but they're limited. They don't have access to just any test, and they don't have access to any therapy, just any therapy. There's so much they do, but also we need to be careful in protecting the patient against a scenario. Let's pretend I have appendicitis, or I think I have appendicitis. If I show up at the urgent care, they don't have access to do blood work, and they don't have access to do imaging studies to look for the appendix. Now, they can talk to you about your symptoms, they can put their hands on your belly, and they can examine you, and that can help guide them to give you recommendations of whether or not this is more or less likely something such as the appendix. But if in any way, shape, or form they think, hey, this would be, you would be better served with some lab work or some testing, then they're going to send you over to the hospital to get the testing done.
Last night I was chatting with my wife, who, as you know, is a pediatrician. I asked if she had any questions to contribute, and she said a common complaint she hears from patients is, I went to the emergency room and they didn't do anything for me. They just told me to follow up with my doctor. So her feeling is that when this happens, it's usually that patients, it's more of an issue about patient expectations. It's about what the ED does well. Can I get your thoughts on all that?
Absolutely. So as a medical director, sitting in an office seat and reading emails, reviewing charts, I also work shifts, and so I get to see it firsthand. But then when I come back and I sit in my office and I look at these cases, it frequently, if not most of the time, boils down to a communication and an understanding issue. Sometimes even if we communicate the reasons why to or not to do certain testing and therapies, it still doesn't meet an expectation. It's hard to breach that gap, but most patients, most of the time, if we spend that extra moment and we're able to describe, hey, this is why we're not recommending this therapy, or this is why we're not recommending a CAT scan, for instance, most of the time patients are very understanding of that. And I find that it works out if we communicate that with a little extra moment.
KRMC is a teaching hospital. I'd like to talk a little bit about the residency program. Medical residents come here to train in family medicine, but also in emergency medicine. What kind of training do your residents receive when they're here?
Oh, right. I love that question. So as a teaching facility, I'll tell you what, there's teaching anywhere from learning how to draw blood. There's teaching for nursing students. There's CNA students. There's new graduated nurses who at the hospital, they have a nurse resident program that they do here. But a lot of times when people ask the question you're asking, they're referencing the physician route. And so we've got a lot of medical students who come through, rotate, and then we have a residency program specific for emergency medicine. So now someone's become a doctor, they finish medical school, but to board certify, you can't even sit for those exams until you complete a residency program. And so we have a fantastic group that comes here for 3 years. They have a lot of focus on the educational component. They see lots of patients. They rotate through other service lines. They'll rotate through trauma service. They'll go to Vegas for that. They'll go to toxicology over in Phoenix and do some training over there. They work over at the pediatric emergency department. These people, they come here and they donate their lives to the community for a 3-year period. Sometimes I hear negative feedback about, oh, it's a teaching program, it's a training program. I've worked at multiple other hospitals. I've worked in other emergency departments. And from my standpoint, usually the fact that it's a teaching program means you get probably 3 to 5 times as much actual one-on-one dialogue with a doctor than you do at some of these other facilities. So I usually find that you get more love and more effort. I haven't found, when I compare to other facilities and other places I've worked, I haven't found that it's less care. If anything, it's more. We talked about the overcrowding issue. We talked about the fact that there's overcrowding also in the clinics. So we end up providing extra counseling and even some primary care level efforts in that process. So it really seems like it's an overall positive.
And what are some of the key experiences you want those residents to have during their time here?
I want them they need to know the gambit of medical conditions. They need to know how to interact with patients. They need to know how to give quality care and know how to manage the critical scenarios. As a doctor, I'm going to disclose the fact that the vast majority of conditions I see in the emergency department, if you didn't come and see me, your body would fix itself anyway, with or without my help. Okay? And I mean the majority. Is it 80%? Is it 70%? I don't know. But I think it's the majority. That's how the body's made, right? It's made to do that. But I want these doctors to come out of this knowing how to have those interactions, give quality care. And then the part that's harder to train is learn how to communicate with the patients to make sure that everyone understands. I've said for years, I can teach a doctor how to take a test. The thing that's harder for me to do is teach a doctor how to interact with people. And so what I've learned, funny enough, is the residents who are the easiest for me and the easiest to train are the ones who have had to work in customer service at some point because they've had to have actual interactions where they get along that way.
Emergency medicine is a different kind of medicine. It runs 24 hours. It can be loud and chaotic. The folks who work around it may be superstitious about full moons and Friday's the 13th. Do you find that the people drawn to this kind of work are a different breed?
They absolutely are, in a wonderful way. You have to be ready to get spit at, punched at, and then walk into another room and smile as a sweet little old grandma needs to talk about the fact that she can't breathe. I've had moments where I'm literally in tears after watching something awful in the community happen, and then I have to go and I have to talk to a family about something else, and I can't bring that to the next room. I have to try to separate those two things.
Well, speaking of something awful, the next couple of questions are personal. I think I have your blessing to ask them. This is a quick story from me. And dear listener, if you're squeamish about these sorts of things, these kind of medical details, by all means, look away from your radio right now. But my uncle was a first responder in a small town. He was a fireman, EMT, and part-time police officer. It's one of these places where he could also be like the notary, the attorney, the liquor salesman, you know. And he once told me this story. So he worked in a college town, and on moving out day at the end of the semester, there was a student who was packing her boxes and getting ready to go. She lifted her mattress, and somehow the box spring exploded, and a spring launched out and impaled one of her eyes. So as you can tell, this image has stayed with me for 25 years, something like that. And as an ED doc, you have a heightened sense of the ways in which the human body is breakable. How do you deal with this sort of thing?
Wow. So a moment ago, you asked if the people who are attracted to emergency medicine are a different breed. The answer to that was yes. I think part of the answer to this question is also the fact that, hey, it's a different breed. I went into this hoping I could help people, right? I wanted to know what to do when something happened also. But the blood, the guts, the scary, the sad, those can be extremely difficult. They can be wearing. The idea of this gruesome event, those gruesome events happen. You don't know when they're going to happen, and sometimes they are life-altering. I've had quite a few cases over the years who have stuck with me. I can still see faces in my mind of patients who years later I'll still have a good cry and still remember that. My wife knows sometimes I just need to talk to her about it. In fact, I've got a brother who's an ER doctor. He and I have a 24-hour arrangement. Anytime, any day, we can call each other when we've got a difficult case. For me personally, the saddest, the most difficult cases are the little kids, when something sad happens to a little kiddo. But we try to treat everyone like family. So you take the really sad, the potential for scary, these awful scenarios like the story you described. But then you think, hey, I want my family taken care of. And so part of how I manage that, and I think how most of us manage that, is we try to treat everybody like our own family. Having said that, if you're a patient or family member listening to this right now, and I've ever gotten angry with you or yelled at you, I would have done the same thing to my own family. The idea being that, hey, we really do genuinely want to help. And sometimes help means, hey, quit smoking. What are you doing? You're killing yourself. Knock it off, right? But I don't know. It's hard. There's probably more to the question you're asking. Am I answering it okay?
You are answering it. My follow-up was, how do you keep from taking that stuff home? But it sounds like you take that stuff home.
Oh, you absolutely do. I've had moments where I go home and I'll actually go hug my kids, even when they're asleep. I'll just hold my wife. And I can't talk, but she knows.
The radio interview is not supposed to be traumatic, and I apologize,
I'm so sorry.
Doc. No,
I can't talk about this stuff and not break down. But I've learned that I'd rather say it, discuss it. I'd rather shed the tear because it's unhealthy not to. I've had opportunities to talk to some of the high school kids in town about some of this. I've had opportunities to teach at a couple of the universities and talk to some of the med students about this. I've had opportunities to try to discuss these in group session with the residents as well, but a lot of it is traumatic.
When the residents have their first real taste of that, what do you say? I mean, is it at first you give them some space and then talk about it later, or how does it?
It depends on them. It depends on the person. There's moments when one case will affect one person really a lot, and then not another, and then a different case, the opposite will happen. Yeah. And so it kind of depends. I try to encourage them to talk about it, though. The saddest thing for me is when people bottle it up and don't allow it to come out, because that can be damaging long term.
So now that we've touched on some of the dark and difficult parts of this job, no, please. Are you okay with all that? Can we use it?
Yes, absolutely. Yeah.
If you were meeting, I'm hoping we're not deterring anyone, but if you were just meeting a brand new doc who said, I'm thinking about emergency medicine, what kind of advice would you give that person?
I would excitedly tell them, good job. I'd support it completely. I usually try to tell people who are interested in it, I try to tell them to make sure to do it for the right reasons. I've learned that not everyone goes into the practice of medicine for the right reason. I've said for a long time, hey, don't do it for the money. I don't find the money to be motivating that way. The idea of doing it to help people, though, I mean, that's long-term. That's long-term motivating and is rewarding in a different way. And so us people in the emergency room, we tease each other that we're all a little bit crazy. But I, as a doctor, have learned that every single person is a little bit crazy. We're all just crazy in different ways. The type of crazy that recruits emergency medicine people is a wonderful and fun type of crazy. And so I would encourage them. I'd say, absolutely, that sounds fantastic. Any job is going to be the run-of-the-mill, even potentially mundane, a certain percent of the time, right? Emergency medicine, if you look up what patients come in for emergency medicine care, there's a top 10 set of reasons, and most people fall into that top 10. If we were to take one condition from that top 10, abdominal pain is in the top 10 reasons why people come to the emergency department. The statistic, I haven't seen it recently, but a few years ago, if you were to take all the people who come in with belly pain, half of them leave the emergency department with us still not knowing with guarantee what it is, what's causing it. And so you have to go through this Sherlock Holmes deduction of what's causing it, why, and try to figure out the detail of it. But otherwise, it's still just a job. The trick is being ready for the difficult, the crazy, the sad. A heart attack is easy. I know how to handle a heart attack. It's 1 + 1 + 1 = 3, done, right? But there's nuances to it. And so you got to be ready for all the little nuances. They're not known for biting people. If they bite, it's the same treatment as any other bite. It's not necessarily dangerous.
I know, it's their size that frightens us more than anything.
Oh, yeah, for sure.
Come on, lightning bolt. Oh, look at you. What a handsome boy. All right, everybody, I'm conquering my fears. I've got a tarantula walking up my arm. That is Dr. Adam Dawson. He is an ER doc, and he's the medical director of the emergency department at KRMC. Dr. Dawson, thank you so much for your time today.
Thank you. This was fun.
That's the program. That's Focus on Your Health. I'm TG LaFredo. Thank you for listening. Stay healthy, and we'll catch you next time. And I'm ready for you to come and get them.